Good afternoon, everyone. Thank you all so much for joining the first meeting of the Comprehensive Health Coverage Commission. My name is Sean Walker, and I am the director of DCH's Project Management Office. And I am so very excited to be working and supporting with the commission as you all embark on this critical mission. Before we get started with today's meeting, I wanted to make just a few notes about the format of the meeting. This commission will conduct meetings in accordance with the Open Meetings Act, which requires that the meetings are made available to the public for viewing. And also, the meetings will be recorded. You should have heard that prompt before we got started this morning. So all meetings will be recorded and also placed on the commission's website so the public can view it at their leisure. During the meeting, the commission members will have an opportunity, the ability to unmute themselves and also use the chat feature. So at this time, I will take a brief roll of the commission members so that we can see who is present on the call. So commission members, please unmute yourselves if you're able and let me know if you're present. Starting with the chair, Kaylee Noggle.
Good afternoon, I'm here.
Lisa Carnot.
Good afternoon, I'm here.
Thank you. Pam Clayton.
Good afternoon, I'm with you.
Thank you. Christy Klein Davis.
Good afternoon, I'm here.
Thank you. Delvecchio Finley. Delvecchio Finley. Dr. Harry Hyman.
Hi, good afternoon, I'm here.
Thank you, Dr. Hyman. Dr. Sid Moore.
I'm here. Thank you.
Thank you, Dr. Moore. Dr. John Odom.
Present.
All right. Thank you, Dr. Odom. Joseph Ross. Thank you, Mr. Ross. And circling back, Delvecchio Finley. Well, I appreciate you all for going through that role with me. At this time, I will ask that we share today's presentation. I'll give a brief summary of today's agenda. If we can bring up that presentation. Thank you, Kai. All right, so today's agenda will begin with a welcome from the commission chair, Kaylee Noggle. Then we will get into introductions by all of the commission members, as well as a discussion on commission housekeeping by Chair Noggle. Then Lynette Rhodes, the Chief Health Policy Officer for the Department of Community Health, will give us an overview of the Medicaid landscape. And then we'll turn it over to Commissioner John King to give us an introduction to the Office of the Commissioner of Insurance and Safety Fire, as well as Georgia Access. Then we'll close it out with remarks by the chair, Kaylee Noggle. So we have a pretty packed agenda, so I will turn it over to Chair Noggle.
Thanks so much, Sean, and welcome to all of our commission members. I've had the opportunity to chat with most of you, and Sean, just a note, I do think Delvecchio Finley is going to join us in just a moment, so look for him to pop on as well. And good afternoon to all of our both presenters, Lynette and General King, as well as all members of the public that have joined us today as well. Again, welcome to the first meeting of the Comprehensive Health Coverage Commission. My name is Kaylee Noggle. It's my honor to serve as the chair of this commission. I'm grateful to Governor Kemp for the opportunity to lead our group and to Lieutenant Governor Jones, Speaker Burns, and all of our legislative leaders for their confidence in this group to produce meaningful work. Currently, I serve as the president and CEO of the Georgia Hospital Association. Prior to that, though, I served for nearly 20 years in various roles within state government, ranging from an entry-level compliance analyst up to roles as the Commissioner of the Department of Community Health, President of the Georgia Student Finance Commission, and as a Division Director within the Office of Planning and Budget. My experience spanned almost every policy in the state, but over the past few years, I've focused explicitly on healthcare, where I have tried in earnest to collaborate with numerous and varied constituencies and organizations to come together towards solutions that promote and increase access to quality healthcare for Georgians. As a state employee, I often said that there is no shortage of opportunity to do good work for Georgians, and I'm excited that this commission serves as another opportunity to continue supporting our state as we intently study the issues before us. I'm thankful that each of you agreed to serve on this commission, and I look forward to serving alongside each of you and to the thoughtful work ahead. But make no mistake, we do have a lot of work in front of us. This commission is scheduled to work and produce semi-annual reports for the next 2 years, with our first report being due by December 1st of this year. In the scheme of things, and at least my calendar, that is a very short amount of time. In a moment, I'm going to ask each of you to introduce yourselves, but first I want to set the stage a little bit about the work that we've been tasked with completing. We have a specific job to do as set out in statute. This commission was created via House Bill 1339 and is codified at OCGA 49-7-156. And I'd like to read an excerpt of that now, as I think it frames nicely the work before us. The purpose of the commission shall be to advise the governor, the General Assembly, and the Department of Community Health on issues related to access and quality of healthcare for Georgia's low-income and uninsured populations. The commission shall be tasked with reviewing the following: opportunities related to reimbursement and funding for Georgia healthcare providers, including premium assistance programs; opportunities related to quality improvement of healthcare for Georgia's low-income and uninsured populations; and opportunities to enhance service delivery and coordination of healthcare among and across state agencies. The commission shall produce a semi-annual report on its findings for the governor and the General Assembly, with that initial report to the governor and the General Assembly being due no later than December 1st of 2024. So as you can see, our range of topics is quite broad, and our time for a first report is relatively short. Each of you, as we'll learn, has a different background, a perspective, and interest, and you were each appointed to this commission because of those qualifications. Together, our charge is to examine options and issue a report of our findings. My intent as the commission chair is to facilitate a thoughtful, fact-based policy discussion on options specific to Georgia, focused on the mechanics of such policy levers. Political conversations will continue around the options that we document, but our job is simply to explore and document them. Policymakers will ultimately debate and decide what, if any, such options are suitable for Georgia. I believe that many folks largely agree that there is more work to do and that progress can continue in an effort to support Georgia's low-income and uninsured populations. But there's no single silver bullet that will solve all of our issues. So I want to encourage us to clearly identify the problems we're hoping to address and the potential various solutions to each that might also exist. No single solution exists that will simultaneously provide greater coverage options to Georgians, solve our workforce challenges, incent physicians to practice in rural and underserved areas, increase provider reimbursement rates, and improve accessibility in a manner that's fiscally feasible. But there are numerous options to consider that address one or more of those areas in an incremental way. Those options are wide-ranging with different impacts, different costs, and different requirements to make them work. And that is where I hope we spend our time. I'm certain that we'll examine what other states are doing in this space, but I would encourage us to keep Georgia at the forefront and look more broadly at solutions that will work here or create new, innovative options specific to our needs. Over the past couple of years, there have been a lot of conversations about ideas in the Medicaid space, but there were few details widely shared about what those models really look like, how they work, who they benefit, and who pays for them. That is the level of detail that we as this commission need to explore so that our policymakers have a more complete picture as they consider making policy recommendations. I'm excited to begin this work with you, and I'm equally excited to get to know each of you over the next 2 years. I want to pause now, and I'd like to ask each of you to introduce yourself and share a little bit about your background and your interests in the work ahead. So I'll let Sean walk us through those introductions.
Thank you so much, Chair Noggle. Starting with Lisa Carnot.
Good afternoon, everyone. I too am very excited to be here this afternoon. And we'll start off with the introductions and thank you, Kaylee and the chairperson, and very excited to be here for the next couple years to see how we can explore those opportunities. As Sean mentioned, my name is Lisa Carnot. I am currently the Vice President of Risk Management at Pruitt Health Corporation. For those of you that are not familiar with Pruitt Health is a long-standing, very represented in the state of Georgia, that covers skilled nursing facilities, hospice, and allied health professionals. We cover mostly Georgia as our roadmap, and then we also cover southern states, Florida, North Carolina, South Carolina, and just created a new acquisition out in Maryland. Our map and footprint, however, remains in Georgia. While I've been at Pruitt Health for about a little over 3 years now, my background primarily 20 years of risk management in the healthcare field, primarily acute care, been in acute care hospital systems ranging from 100 to 200 beds all the way up to 1,000 bed systems across Georgia as well as other states. Being a risk manager, procurement of insurance, and also looking at traditional risk management on the defense side. Primarily also one of my roles and responsibilities is quality and patient safety. So as we look and kind of look at how we can endeavor into these opportunities for Georgians, there's one thing about access, but there's also another thing about quality. So one of my stronger suits, perhaps, when we talk about our talents here, would be solution-based, value versus volume, moving towards more of the traditional risk management space, but looking at enterprise risk management that more focuses on 4 models that we look at: the financial impact, the innovation that a lot of us can take opportunity on, the consumer base, where our consumer profile is, and then also operations. So that's pretty much my background. I look and chair the Waste Transformation Committee. I do believe that healthcare in general, there's a ton of waste that goes on in our facilities, in our hospitals, and how we can improve quality. Not only just making sure that regulatory is on the forefront, but exceeding the regulatory recommendations is always my motto, so that we can be an offense rather than defense. Higher quality and quality improvement process. While I'm not a black belt certified, however, process is one of the things that I focus on, and kind of looking at how we can do transformation in a more innovative sense in healthcare as it continues to change and exponentially keep us on our toes. Again, I'm really excited to be here and looking forward to the opportunities and working with each and every person here today. Thank you.
Thank you so much, Ms. Carnot. Thank you. Pam Clayton.
Good afternoon, everyone. Chair Noggle, other commission members, I'm grateful for the opportunity to be here with you and embark upon what is a significant charge to the commission, lots to undertake, but certainly work worth doing, and really excited about the work before us. Presently, I work with the Georgia Healthcare Association, supporting skilled nursing providers, assisted living, home and community-based service providers in the areas of quality advancement and regulatory affairs. I am a nurse by background. Prior to joining the association about 9 years ago, I worked with a not-for-profit health delivery system for probably, about 20 years, and had a presence across the state of Georgia, and certainly grateful for that time with that organization, working in senior leadership, looking at the strategic direction, but also thinking about areas from the bedside to the boardroom. So it covered a lot of ground in that space, and it was informative work for sure. Again, a significant charge, and just really interested to explore certainly how we can serve the population that this work is revolving around, and really thinking about the healthcare continuum as a whole. And certainly as Georgia continues to be very attractive to growing and welcoming new residents, but also as we serve an aging population, thinking about how we continue to build the infrastructure across the healthcare continuum to ensure that we are appropriately serving individuals in the best possible way to promote quality outcomes, to ensure, the right care, right setting at the right time, and exploring as we look at data and the different pieces of information that I'm sure we're going to have access to, thinking about, what is working really, really well today, what can we enhance, and then certainly how can we, maybe even expand our reach and support others. And that may, involve looking at specialized service models in different settings. But again, really excited about the opportunity and grateful to learn more about each of you. Thank you.
Thank you so much, Ms. Clayton. Christy Klein Davis.
Hey, everybody. Also very grateful to be here. I'm hoping my video and audio is working. I can't see much right now, but happy to introduce myself. My name is Christy Klein Davis, and I currently serve as president and CEO of the Georgia Health Initiative. We are a private independent foundation that works here across the state of Georgia on opportunities to increase health and well-being for people across our state. I think it's important to note, as an independent private foundation, we do all of our work off of a private endowment. So we're not fundraising. We don't get any dollars from anywhere else other than ourselves. So we come with a fairly independent viewpoint on what we think would be best for Georgians in terms of, again, increasing opportunities for health and well-being. We do our work through a combination of activities. We do commission and support the creation of research, and our research, we hope, is timely and adds to important conversations happening across the state related to health. We also do a fair bit of work in the convening space, so bringing cross-sector groups, cross-geographical groups together to have those important conversations about how we increase access to health. And perhaps what we're best known for is about a 25-year history of a grant maker, where we have provided funding and support to a strong network of partners across the state of Georgia that are serving people that fall into the low income or moderate income Georgians that we're looking to support through this work. Because of that, we have a strong network of partners throughout the state, both nonprofit organizations as well as safety net health providers, so our FQHCs, our mental health boards, et cetera, all those groups that are working hard to meet the full range of needs of Georgians. I was lucky enough to join the initiative about 2 years ago. In sharing a little more background, I moved here 2 years ago and did this work in another state where, again, we had a strong working relationship with our state Medicaid office, our DCH, the FQHC network, and others, and really looked at how we could think about state funding streams, federal funding streams, et cetera, to create networks of care that, as others have stated, not only increased access, but also increased quality and affordability of care for all people across the state. So looking forward to working on doing that here as well. Couple other little pieces of background, because I think it's all relevant. My educational background is in social work. So I constantly look at the world through that person and environment lens. So my viewpoint is, what's the experience of the person that's trying to access care through these systems? It's trained into me pretty hard. So that's part of the viewpoint I'll bring. And I think also relevant, I am a mom who had a daughter this year who was really, really sick. And despite having good insurance coverage and having great access and networks, it was really, really hard for us to get the care that she needed. She is well now, but having gone through that experience personally, it feels really important to me to make sure that more Georgians don't have that kind of experience that I had, again, trying to get my daughter well. So like others, I echo the thanks for the opportunity to be here. Thanks to the Lieutenant Governor for this chance, and I look forward to working with everybody. Thanks so much.
Thank you so much, Ms. Davis. Delvecchio Finley.
Nicely done. The pronunciation generally trips people up, so I appreciate that.
Sure.
Good afternoon, everyone, esteemed colleagues, our Chair Noggle, Kaylee. It is quite a privilege to be here. I apologize. I believe I may have missed roll call. I was rounding on some of our patients here at Atrium Health Navicent, and it went a little bit longer, but we have a motto, patients first, and so I was honoring that, but my apologies, no less. As mentioned, my name is Delvecchio Finley. I do have the privilege and honor for the past 3.5 years of serving as president of Atrium Health Navicent. Recently took on a bit of an expanded role to oversee all of the state of Georgia for Atrium Health, which includes our market here in Central and South Georgia, but also our market up in Northwest Georgia, concentrated principally with Atrium Health Floyd in the Rome area, but also goes into Northeast Alabama. So very privileged and honored to serve with my colleagues and all of our teammates across not just the state of Georgia, but Atrium Health is now part of Advocate Health, which is one of the largest not-for-profit health systems in the country. I am really want to issue my thanks to our state leaders, our governor, our lieutenant governor, our legislators, including Commissioner Parrish and others who gave me the opportunity to join this group of esteemed colleagues that serve in this very important commission. My background, as I mentioned, I've been a healthcare administrator predominantly, actually, the bulk of my career in the state of California. But I have the privilege and honor to say that I am Georgia born and bred as a Grady baby and grew up in my childhood in Atlanta and did my undergraduate studies at Emory. So glad to be back in our great state and serving our fellow residents and providing healthcare. At Atrium Health, our mission is to improve health, elevate hope, and advance healing for all. We shorthand that and call it our For All mission because we very much believe that healthcare is something that everyone deserves and needs, and we do everything we can to be in furtherance of our ability to serve our communities in all of our communities. And we very much appreciate the strength of partnerships and collaborations, and that's across the delivery perspective, but that's also in the regulatory perspective, in the payer perspective, obviously in academia and others. And serving on this committee and commission gives me affords me the opportunity to do that from a professional perspective, but as was mentioned by my prior colleague or commission member, Ms. Davis, also from a personal perspective. As I mentioned, Grady baby, I was raised by a single mom in public housing in the city of Atlanta, and benefited greatly from the generosity and the richness of our state and our country to provide resources that provided access to care and other resources that I otherwise would not have had availability or accessibility to. And I understand how that contributes to the ability to lead full and enriching lives that we all want for ourselves, for our families. And so I understand the importance and the gravity through which we do this work to support our legislators and others who will also do their important job at making some tough decisions and advancing some policies and positions that I know are in furtherance of that shared mission that we all have. So with that, I just want to say thank you again for this privilege and this honor, and I look forward to the tough work that we have at hand and to roll up my sleeves and work with all of you to do this work. So thank you again.
All right, thank you so much, Mr. Finley. Dr. Harry Hyman.
Hi, good afternoon. And I'll echo everyone else's thanks. I really appreciate the opportunity to work with all of you and the opportunity to both inform and move forward health policies in our state. I'm currently a clinical professor in the Department of Health Policy and Behavioral Sciences at the School of Public Health at Georgia State University. My path there has been pretty non-traditional. I came to Georgia in 1989 after finishing my family medicine training and practiced family medicine in Marietta, Georgia for 20 years, and increasingly recognized that patients that needed to come in and see me the most were the ones that experienced the greatest barriers to getting in. So got a master's in public health at Rollins School of Public Health at Emory, and decided that I wanted to make a career transition from full-time primary care to health policy and public health. Had the opportunity after 20 years of practice to move to Morehouse School of Medicine, where I was at the Satcher Health Leadership Institute and directed the Division of Health Policy under former Surgeon General and Assistant Secretary of HHS, Dr. David Satcher, and spent 8 years there, including a year during that 8 years as a Robert Wood Johnson Health Policy Fellow in Washington, D.C., where I worked on Capitol Hill with committee staff in the House Energy and Commerce Committee, their health subcommittee, which oversees both healthcare and public health policies. And 7 years ago, made a transition to Georgia State School of Public Health, where I, in addition to training public health professionals in health policy, also direct our applied public health doctoral program, where we take folks from federal, state, local public health agencies and other organizations and position them and prepare them for leadership roles in public health. My personal area of greatest interest really over the last 15 years has been the intersection of health policy and health equity. I've had the opportunity to serve as a board member and board chair for a state health policy and advocacy organization, Georgians for a Healthy Future, for purposes of full transparency. I'm no longer a member of that board or a board of any other organizations doing work directly or indirectly related to health policy in our state, but really bring to this commission both a deep passion for and interest in advancing policies in our state to address both the profoundly high uninsurance rate that we have in our state, as well as the other barriers that we have, particularly targeted to low income and uninsured folks achieving their full health potential and realizing their full health opportunities, and closing the profound health inequities that we have in our state. So again, very excited to be a part of this and really look forward to the opportunity to both learn from and work with the other committee members to move things forward in our state. Thank you.
Thank you so much, Dr. Hyman. Dr. Sid Moore.
Hey, Sid Moore here. Like the rest of the group so far, I'm very honored and pleased to be a member of this work group. I think that we'll have the opportunity to do a lot of good for Georgia. I'm a practicing ophthalmologist in Macon, Georgia. I've been in practice for 35 years now. Our practice actually had the first ophthalmic ambulatory surgery center in the state. They already had it when I joined the practice. So we've got a lot of experience with providing ambulatory surgery center care to our patients. I've been involved in some other organizations as well. I was a founding board member of the Georgia Society of Ambulatory Surgery Centers. I'm the past president of that organization, and I'm currently legislative chair of that group. I'm also a member of the Georgia Society of Ophthalmology, again, a past president and the current legislative chair of the GSO. Been an active member of the Medical Association of Georgia, where I serve on the board of directors, also on the council on legislation, where we try to make policy for MAG and have an effect at the Capitol. I've also been a past board of director of the Political Action Committee of MAG. I was a founding board member of a accountable care organization here in Georgia that at one time was the largest physician-led ACO in the state. I've also been asked to serve on a commission, the Athletic and Entertainment Commission, which I was asked to serve on that. I frankly didn't know what it was. I found out it's the old fighting commission, but I serve on an advisory capacity there, on a healthcare advisory capacity. And my background, I grew up in a medical family. Both my father and mother were family physicians, practiced together. I've got a sister that's a family physician, a first cousin. He's married to a pediatrician as well. An uncle who's an OBGYN. So I kind of grew up immersed in medicine. I ended up choosing ophthalmology as my path, which I've been very, very happy with that. And, I hope to you get input from everyone on this. It's a great group. It's going to be a wide diversity of outlooks. I'm really interested in exploring, ways we can find to simultaneously save healthcare dollars for Georgia while improving access and quality of care. So again, thank you for the opportunity. I really appreciate it, and I'm looking forward to the next 2 years. Thank you.
All right, thank you, Dr. Moore. Dr. John Odom.
Hello, and nice to be here. I'm John Odom. I'm a surgeon in Savannah, Georgia. I'm a longtime board member of St. Joseph's Candler Hospital in Savannah. I'm a delegate at large to the American College of Surgeons. I'm a professor at the Medical College of Georgia and an assistant professor at Mercer Medical College. I'm very active in education. I'm a program director of an approved program in general surgery located here. I grew up in South Georgia in a very small town called Araby. I don't know if anybody's ever heard of it. So I think I'm pretty well versed when it comes to the needs of healthcare needs in rural areas. Here at St. Joseph's Candler, we are very much a not-for-profit hospital. We run 2 free clinics that see 33,000 impoverished Georgians every year. I do most of the surgery for those clinics. In addition, we have 2 other free clinics here that we work very actively with. So I'm fairly well versed in urban needs as well. My big passion is the upcoming terrible crisis we have in our as far as our physician shortage goes in Georgia, and that's where I've done most of my work. I've been quite active in establishing our new medical school here in Savannah, and happy to be here. Hope I can help. Thank you.
Thank you so much, Dr. Odom. Joseph Ross.
Yes, please. Everyone knows me on this phone call knows to call me Rusty. And
okay.
I am certainly honored to be a part of this group, Madam Chair and Commissioners. As I've listened to you go over your bona fides and resume, I must say I'm very impressed both with the knowledge and the breadth of where this comes from. Several of us, of course, represent providers, but there are also patient representatives here too, and I think that's very important. I think the legislature has done a tremendous job in the governor's office and the legislature in putting together this commission. I am a lawyer, and so I have to start off with that. So deal with it. Been a lawyer for a long time now. 43 years. I've had 3 jobs. One was in a local law firm here in Savannah, and then for 12 years as general counsel and senior vice president at Memorial Health University Medical Center here in Savannah. And that was really, I think, where I get my bona fides for being on this commission, because Memorial is certainly one of the largest indigent care providers in the state at that time, and still is today, I believe. It's been a long time since I've been there. But I spent a lot of my time trying to figure out how to get funding, where it's coming from, how to deal with providers, and also reimbursement sources. And I think that that hopefully will serve this commission to some extent well. It's not my first commission I've been on. I was also on the 2005-2006 State Commission on the Efficacy of Certificate of Need law, which resulted in the 2008 revisions to the law. And that was an interesting process in and of itself. I represent, to this day, all sorts of providers: hospitals, physicians, durable medical equipment providers, ambulatory surgery centers, and so forth. And I find they're all dealing with the same problem, and that is we've got a lot of people to see, we have limited resources, and there's tremendous regulatory red tape in getting it all done. And so I would hope this commission would spend some time focusing on making our system more efficient, as well as, of course, getting as much money as we can from whatever sources are available, but mainly making this process more efficient, providing more resources for those that are terribly in need in our state. I'm an old guy. I've been married for 43 years. I've got one son and daughter-in-law and 5 grandchildren from the ages of 13 to 4. So I have had some experience with dealing with difficulties and acrimony, I promise you. Anyway, that's about all there is to me. And I hope that we can get to work, roll our sleeves up, and produce for our state what they've asked us to do. Thank you.
All right. Thank you so much, Mr. Ross.
Thank you all. Thanks to all of you for taking a moment and introducing yourselves. I think it's helpful for us to all have kind of an understanding of our different perspectives and where we're coming from. Also, just thank you for the service that each of you are doing in your day in and day out jobs, advancing the healthcare for Georgians. So thank you. I think it's really clear from listening to all of you that our state leaders chose wisely and assembled a really strong cross-section of subject matter experts. I also just want to take a moment and introduce our support team from DCH. The commission is, quote, administratively attached to DCH, which just means they help on our back end with our logistical support. There's a tiny, and when I say tiny, I mean really, really tiny amount of money in the budget to help with a consultant to write our report. And they help do some of those administrative things. Ms. Sean Walker introduced herself. She's the director of the project management office at DCH and will serve as our project manager. And Ms. Kylan Gallagher, goes by Kai, will serve as our administrative assistant and will help us with all of our meeting planning and logistics, updating our website. In fact, they've already established a web page for the commission on DCH's website, and you can see the web address there. They've also created a general email address that both our commission members and the public or media or anyone else can use for inquiries or comments. And then you are welcome to share with folks that reach out to you as well. And that's chc.commission@dch.ga.gov. Sean is a 20-year state employee, so shout out to her. But she will be your #1 go-to, as will Kai, for any of your logistical needs, questions. I've had the privilege of working with Sean and the team previously, and we are so lucky to have them working with us on this project. They are top-notch, and I am grateful, and we owe you already, Sean and Kai and team, so thank you. My job will be to help keep us on track and moving forward, exploring the issues we need to thoroughly, but also pulling us back or not letting us stray too far from our scope, the scope of work from time to time. So with that, let's dive in. To start our work, I think it's important that we all have the same understanding of how Medicaid and our insurance markets work today in Georgia. Medicaid has expanded benefits in Georgia over the last few years by extending postpartum coverage up to 12 months. Medicaid increased rates paid to certain providers for certain specialties over a number of years, and have added benefits for specific coverage benefits in the last few years as well. And then there's new data highlighting the number of Georgians that have gained coverage through Georgia Access on a commercial plan with federal subsidies. And I think it's important for us to understand those as we start. To help us set that landscape and ensure we all are starting with the same set of facts, I've asked both the Department of Community Health and the Office of the Commissioner of Insurance and Fire Safety to help set the stage for us today and ground us in current factual data that exists around Medicaid, our existing programs and waivers, and the insurance landscape in Georgia. After we all have that same understanding on how the programs are currently working, the data surrounding them, and where those gaps exist, then we'll progress our study even further. I think it's important to note that we can examine all the options that will come before us independently, and that, in my view, more options are always better, and no existing programs or benefits necessarily need to end in order to consider more. So first on the agenda is Lynette Rhodes. She serves as the Chief Health Policy Officer from the Department of Community Health, and she's going to lead us through a Medicaid primer. She has worked in various capacities at DCH for nearly 20 years, including as the Executive Director of Medical Assistance Programs, which is our state equivalent of Medicaid Director, and as the Director of Legal Services. During her tenure, she's also served in leadership roles with the National Association of Medicaid Directors. And prior to joining DCH, Lynette worked as a public defender with the city of Atlanta, so she brings great experience. So Lynette, welcome, and thank you.
Thank you. Thank you, Chair Noggle. Just want to confirm that you all can hear me. Okay, awesome. On behalf of Commissioner Russell Carlson, I do want to thank you all for the opportunity to present today. This is a great opportunity, a great board, a committee of commissioners. I know a few of them that we work with very closely, Pam Clayton being one. Rusty, it's been a while, good to see you. And so again, thanks everybody. Sean, if you all could advance really to slide number 5. All right, so we're going to dive in. Some of this, many of you will already know, but for those that don't, we wanted to make sure that we gave a broad understanding of how the Medicaid program operates today nationally and also in the state of Georgia. So as a starting point, the Medicaid program is a jointly funded entitlement program that pays for medical assistance for individuals with low incomes and limited resources. The program is administered by the states within very broad federal guidelines. And that's a critical point for this commission to take away, because in essence, there is no one size fits all. Each individual state operates their Medicaid program differently. Each state has the flexibility to determine the eligibility requirements, the scope of services that are provided, the payment levels, the methods and reimbursement methodology. The program primarily serves low-income families, of course, pregnant women, children, newborns, individuals that are aged, blind, or disabled, and we are also the payer of last resort. That is also something that I wanted to take just a moment to talk about. The Medicaid program is responsible for always ascertaining any legally responsible third parties. And we do have members who actually have primary coverage in the commercial space as well as Medicaid. So in those instances, we always have to look to the commercial plan to be the primary payer first, and then Medicaid payments will take place secondarily. It's also, I think, interesting to note that overall, nationwide, while the aged, blind, and disabled population tends to be the smaller portion of our Medicaid members, they are, in fact, the most costly. And that has been the trend nationwide for decades. And so even though they're the smaller percentage of the population, the fact that many of them are in skilled nursing facilities or receiving long-term care services helps to cause that increase and that enhanced expenditures. Next slide, please. There are currently approximately 76 million members nationwide receiving Medicaid. It is the largest payer in terms of healthcare services. But as I mentioned earlier, it's funded jointly by federal and state dollars. So when we talk about the federal portion, that is determined by a federal matching rate. So in essence, the federal government applies a particular formula, and that's done annually. And from that formula, each state is assigned a particular federal matching rate. The minimum rate is 50%. The maximum rate is 83%. So as you can see from this last bullet here in the state of Georgia, our FMAP for federal fiscal year 24 is 65.89%. And for federal fiscal year 25, it will be 66.04%. And this varies amongst states, and it also varies amongst the different program types. So while this is in fact the FMAP percentage for the Medicaid program, there is a different FMAP percentage for the CHIP program, which we'll talk about momentarily. The FMAP ultimately determines how much money we're going to receive from the federal government to cover our Medicaid expenditures. And so it's designed, the FMAP percentage is designed to provide a higher percentage federal match to states with lower per capita incomes. Next slide. So here I've just given you a glance, just high level, a few states, so that you can see the variations in their FMAP percentages. So I highlighted Georgia here in the middle, of course, but if you look at New York, for example, they are one of the states that have the minimum FMAP rate of 50%. And then, of course, Texas, Alabama, Florida, Mississippi, those are listed here. Just an interesting fact to note, for the U.S. Virgin Islands, for Guam, and for American Samoa, their FMAP percentage rate for federal fiscal year 25 will be 83%. So they will be at the highest level for FMAP. Next slide, please. In order to operate a Medicaid program, any state has to have an approved state plan. The state plan is in essence a comprehensive written document that really serves as our agreement between the state and the federal government. And this particular document, which is pretty significant in size, outlines the basic eligibility criteria, coverage limitations, and high level the services we provide and the reimbursement methodology. We have a copy of our state plan online. I've provided the link here in case any of the members of the commission want to go back later to take a look at that. Anytime we make an amendment or a change in our programs or policies, it requires a state plan amendment. And so we have to go back quite often and make revisions. For example, each year at the conclusion of the legislative session, we come together as a team and analyze all of the mandated changes in the appropriations bill. And we also look at any type of legislation that was enacted. And based upon those decisions from our General Assembly, we may have to go in and make amendments to our state plan. Next slide. Want to shift to the CHIP program, or the Children's Health Insurance Program. This is also a jointly funded program, but the focus here, of course, is on children under age 19. This is designed for families with incomes that are generally too high to qualify for Medicaid, but they also can't afford private coverage. And so in the state of Georgia, for our CHIP members, there is state law that's found in the Official Code of Georgia's Title 49 that outlines all of our requirements for the CHIP program. And I'll give you a little more detail on what's happening in Georgia with respect to CHIP in some of our future slides. The last note here, one of your takeaways is that CHIP is not an entitlement program. So unlike Medicaid, if there is a decision to suspend or terminate or reduce services, unlike Medicaid members, the CHIP members typically do not have the right to appeal those decisions. Next slide. So we're going to shift to the Georgia Medicaid and Peach Care for Kids programs. Next slide, please. So as a starting point, every state must have a single state agency that is designated to administer the Medicaid and CHIP programs in those states. In the state of Georgia, it is the Department of Community Health, and that is noted in state law, as well as also in our state plan. So we oversee all of the program administration, but I do want to note we do not do this alone. There is no way that we could run this program alone by ourselves. So we garner a lot of support and assistance from our sister agencies. The Department of Behavioral Health and Disabilities would be one example. We work very closely with the Department of Human Services and the Division of Family and Children Services. The Department of Juvenile Justice is another example, and the Department of Public Health and the Department of Education. So all of these state agencies come together to help to administer the Medicaid program. In Georgia, our combined federal and state budget is currently $18 billion annually. Next slide. So in Georgia, we operate a fee-for-service model and a managed care model, and they are very different in terms of how they operate. When you're talking about fee-for-service, that in essence means you have a provider that renders a service and payment is made directly to that provider. In the managed care space, you have various entities. Currently in Georgia, we have 3, Amerigroup, CareSource, and Peach State. They're listed here on this slide. And the way it works in the managed care space is that we pay per member per month. It's called a capitation payment. We pay that specific rate to these managed care entities each month, and they are required to coordinate care and manage care for our members. Currently, we serve approximately 2.3 million members in our Medicaid and Peach Care for Kids programs. 1.7 million of those members are currently receiving service in the managed care setting, with the remainder receiving services in the fee-for-service setting. It's important to note here one change that is going to take place in the very near future. We will be shifting a significant portion of our fee-for-service population to managed care. And that is the trend nationwide. Most states are going full-blown managed care. And so while we will not transition all of our fee-for-service members into managed care, the majority of them will transition over in future years. Next slide. Here, I just want to demonstrate for you the trends in terms of enrollment in Georgia for the Medicaid space. So I thought it'd be interesting for you to see how things look back in 2009 through the current year, 2024. So as you can see, enrollment has steadily increased over the years. During the COVID years, those numbers increased even more. Between 2023, well, I would say between 2021 and 2023, our enrollment numbers grew to 2.8 million and actually a little over. That was the highest enrollment we had ever seen in the Georgia Medicaid program. We've now completed redeterminations. The public health emergency has ended. And so now those numbers are slowly coming back down to our pre-COVID rates, again, around 2.3 million. Next slide. So here I wanted to show the commission some of the services that we provide in the Medicaid space. So as you can see here, it's broken out into mandatory services and also into optional services. The mandatory services are the core services that every single state Medicaid program must offer. And these are very similar to what you will see in the commercial space. These are mandated by federal law. The optional services are not required by federal law, but most states provide them and so do we in the state of Georgia. But again, this is just very high level, just to give you a feel for the types of services that our members receive. Next slide. So I want to take just a moment to highlight some of our recent program changes, and Chair Noggle touched on some of these in her introduction. So first off, express lane eligibility. The reason why this is important is because we use other social programs to help to identify members who may be eligible for Medicaid. So in Georgia, we look at individuals who are receiving services through SNAP, which is our supplemental nutrition program. We look at individuals who are receiving services through the TANF program, our temporary aid for needy families. We look at the WIC program, which is our Women, Infants, and Children's program. We also look at the Refugee Cash Assistance Program, Child Care Program as well. So we can look at those social programs, see who's enrolled there to help determine whether or not those individuals are eligible for Medicaid. And recently, we've gone from an opt-in model to an opt-out model. And what that means is that if you qualify for those other programs, we will automatically review you to see if you're eligible for Medicaid, unless you tell us you do not want that to occur. So we've changed that model versus having the individual say, yes, please consider me for Medicaid. So that's a significant change and will definitely allow us to identify individuals who qualify for Medicaid who we may not have considered previously. 12 months continuous coverage for children went into effect in January of this year. And so this is very important because what it does is it ensures that any child under the age of 19 will remain covered for a full 12 months. So this eliminates the churn that we would see previously, where members come in, they drop off, they come back, they drop off. And so this helps to ensure continuity of care for all of our children, which is important for things like your EPSDT screenings, vision, dental, hearing, and those types of services. 12 months postpartum coverage is also one of the recent program changes that we put into place. So that allows our pregnant moms to continue to receive services 12 months after they deliver or after the end of the pregnancy. Coverage of clinical trials was another change that we made, and this was mandated by federal law. So all states now cover clinical trials. We've added new service types, new provider types. Lactation consultants stands out in the forefront of my mind. Behavioral aids is a new service type that we've added recently. And over the past few years, we have done a host of provider rate increases. For example, those include dental rate increases, increases for our primary care physicians, some of our facilities as well, our PRTFs, those are our psychiatric residential treatment facilities, our nursing homes. So that's been ongoing for the past few years. And then the addition of the Pathways 1115 waiver. So all of these help to increase and improve access. And so we'll continue to try to identify those, and hopefully with the assistance of this commission, we'll identify some policy changes going forward. Next slide. Here we've just given you some high-level data and trends for state fiscal year 2023. So here we've highlighted for you some Medicaid enrollment data. So on average for fiscal year 23, we enrolled 2.6 million members, and the average cost per member was $410.33. So you'll look at the trend here, which is from 2019 to 2023, and you see this drop. And that is in part due to the public health emergency. And so I'm sure each of you will recall that during that period, there was a challenge to get members to utilize services. and to actually utilize, things like telehealth. There were concerns about going into practitioners' offices, and so that's the reason that you see that drop there. But despite that, in fiscal year 23, we paid over 60 million claims, $6 billion net payments, and the capitation amounts are reflected here for you as well. So total payments are noted here in the middle column, just for the group to be able to get an understanding of overall what our Medicaid expenditures look like. Next slide. So here is the payment distribution by category of service. The majority of our members are enrolled in managed care. Again, those three entities, Amerigroup, CareSource, and Peach State. So the majority of our payments here are reflected in capitation payments, which is the light blue area. The other areas represent our services for our fee-for-service members. So for example, nursing home services, some pharmacy services for our ABD population, and then our waiver program services, which I will talk about momentarily. Next slide. Peach Care for Kids is Georgia's CHIP program. And so I thought it'd be interesting to show the group here what the stats look like during the last fiscal year. So on average, we enrolled 204,000 members in our Peach Care for Kids program. And the average cost per member per month is $189. So you can see here the total payments that we've made in the center column. And then you'll note kind of that same dip in terms of services, which took place during the public health emergency, but that has also increased due to the utilization of telehealth and the very aggressive communications and encouragement to get our members, our children particularly, to go in and receive their EPSDT services. So our vision, dental, screenings, and those types of services. Next slide. So here we outline for you just the distribution by category of service. Here you'll see that the light blue area, which represents capitation payments. And this is because the majority of our Peach Care for Kids members are served in the managed care space. We have very few that are in fee-for-service. So overall, the expenditures there are with our CMOs. But for those that fall outside of that, we've listed that for you here. So some pharmacy services, dialysis, and those types of services for those that are in fee-for-service. Next slide. So I want to shift to talk about approved waiver authorities. Next slide, please. So one of the questions that we often get is, well, what is a waiver? We kind of throw that term around really loosely. And so a waiver basically allows us to avoid or not comply with certain federal regulations. It allows us to waive those regulations. So things like requiring that the service be available statewide. Things that require, for example, that they be consistent with other programs. So these are the types of federal rules and regulations that we can waive and not comply with for certain programs. And waivers, in essence, allow us to test, to look at ways to experiment to see, does this service actually work? And is it beneficial for our members and the state of Georgia? So we actually have home and community-based waivers that have been approved by CMS. And we also have Section 1115 demonstration waivers as well. And then, of course, the Section 1332 waiver, which is our Georgia Access Program. Next slide. So here I want to talk about our home and community-based waivers. So these are Georgia's 1915C waivers, and we have 4 of those today. And these are in part administered by our sister agencies, one being the Department of Behavioral Health and Developmental Disabilities. So the 4 waivers are our elderly and disabled waiver. It's commonly referred to as EDWP, and we'll talk about that in just a moment. We have our comprehensive supports waiver and the new options waiver, and also our independent care waiver program. And each waiver serves a different and unique population. Next slide. So for our home and community-based waivers, there are just some very common characteristics here. I won't read these out to you, but in essence, they all require that you meet a certain institutional level of care, whether that's a hospital level of care or a nursing facility level of care. And the benefit of the waiver is that it allows you to receive those services at home in the community setting. That's the whole purpose of the waiver. Of course, we have to determine your eligibility, and the services cannot cost more than it would cost to serve you within the institution. All of our waivers do require estate recovery. And for those who are not familiar with that term and that concept, what that means is once that member passes away, that member's estate will be required to reimburse the state of Georgia for services received. We were one of the last states to implement estate recovery, but it is a federal requirement that all states are required to comply with. All of our policies and procedures for our waiver programs are posted on the DCH website and are available by selecting the link that I've included here. Next slide. So let's kind of dive into each of the waivers and talk about the particular populations that they serve. So first is the Now Comp waiver. We typically combine these, but this program is operated by the Department of Behavioral Health and Developmental Disabilities. Next slide. So again, home and community-based waiver, and this is for individuals that have developmental or intellectual disabilities. That is the particular population that's served under this waiver. You do have to have an evaluation, and the typical services that are provided here would include supported employment, PTO/TST, community access, community guide, and community living supports. So these are things that help the individual to remain and to flourish in the community setting. Next slide. We have the Independent Care Waiver Program. Now, this program is operated by DCH, along with one of our vendors, Alliant Health Solutions. Next slide. So this waiver serves individuals with physical disabilities or persons that have a traumatic brain injury. And this is only for persons ages 21 to 64. And typically through this waiver, our members receive personal support services that assist with the activities of daily living. So bathing, dressing, clothing, toileting, transferring. They also receive case management services. We provide skilled nursing services through this program as well. And for individuals in the ICWP, if they require home modifications, this program provides that service as well. Next slide. The Elderly and Disabled Waiver, also called EDWP, is also administered by DCH. Next slide. And so this program is really 2-in-1. It consists of the Community Care Services Program, also referred to as CCSP, and our SOURCE program. So they used to be separate programs, but we decided to combine them into one program to make it more efficient. And so this is specifically for our elderly and disabled population. And through this particular waiver, individuals can receive the same type of personal support services that I mentioned before. So the assistance with activities of daily living, home delivered meals, and adult day health. And this is just a high level snapshot. There are many more services that are available through each of these home and community-based waiver services. And so it's a very comprehensive, these are all very comprehensive programs. Next slide. So I want to shift to our 1115 waivers. We have 2 of them in Georgia. The first that's listed here is our Planning for Healthy Babies. And so in this waiver, it's designed to assist women who are uninsured, who otherwise would not be eligible for Medicaid, or for women who have delivered low birth weight babies. And then we also have our Georgia Pathways to Coverage program, which just went live a year ago, July 1st of 2023. So next slide. So again, here, the Planning for Healthy Babies, we've identified the criteria for you here. And the members that are in Planning for Healthy Babies receive what we call family planning related services. So they'll get access to primary care services, contraceptives, testing for sexually transmitted infections. They have a resource mother that's assigned to them that can assist with coordination of care. So if they need transportation to doctor's appointments, assistance with gaining access to medications, all of that is available to them in the Planning for Healthy Babies program. But it is a limited scope of services, and those services have to be related to family planning. Next slide. Pathways to Coverage is our next 1115 waiver. And so this is a very unique program, the only one of its type in the nation. And so I've listed for you here just some of the goals that were considered in the development of this program. And Pathways is the result of the Patients First Act that was signed into law by Governor Kemp. And in essence, the goal here is to reduce the number of uninsured Georgians and to help them to become independent and to transition off of Medicaid onto a commercial health plan. So if you transition to the next slide, I just want to talk about some of the unique components of the Pathways to Coverage program. So it's designed for persons who otherwise are not eligible for Medicaid. The age range is persons ages 19 to 64. And the unique component of this program is that you have to meet qualifying activities. And again, there is no other program of this type in the nation. And so the qualifying activities include things like employment. So this could be employment through self-employment or sponsored employment. Higher education is also a qualifying activity. So college students who don't have insurance could potentially qualify for this program. On-the-job training is a qualifying activity, or participation in Georgia Vocational Rehab. That's another example of a qualifying activity, and community service. And so we continue to explore ways in which to promote Pathways and to get our residents of the state of Georgia who are uninsured to enroll. And so this has been a great opportunity for us to stand this up. Again, it's still in its infancy, first year. And so we'll continue to work to improve the program going forward, make a few policy changes, and increase enrollment. And you do have to demonstrate that you're meeting 80 hours per month of any qualifying activity. Next slide. So I know I'm getting close to time here, but I wanted to just emphasize for the group, and it's interesting in listening to the commission's introductions of themselves and their concerns. These are the policy considerations that I hope that this group, will take into consideration. And you all touched upon many, if not all of these in your introductions. So when we talk about increasing access to care, these are all of the considerations, and I'm sure that there are others, but access to providers is one key component. And so we know that there is a shortage today of providers. We know that we are facing a high level of retirements of physicians. And so that's something that has to be considered. Reimbursement rates is another consideration. And I noted that here, because that requires appropriations. Again, remember, Medicaid is jointly funded by both federal and state dollars. The ultimate goal that I think we all want to see is improved health outcomes. So that's listed here as a policy consideration. Member and provider incentives is also very important because we do have to remember who the Medicaid population is. And this is nationwide. So how do we incent and encourage members to participate in their own health care? And how do we encourage providers to continue to participate in the Medicaid space? The priority areas of concern for Georgia, some of those I think we all know include things like behavioral health, reducing chronic conditions, addressing behavioral health needs. So those are some of the priority areas. Technology. We cannot increase access without considering technology and expanding that. So telehealth, of course, is one way that we do that today. And in the Medicaid space in Georgia, many of our services are available via telehealth. Integrated care models is something else that we're looking at. And so there, the integration of physical and behavioral health. How do we do more of that? Of course, the policy requirements. I think someone touched upon that in their introductions, right? So, what are the requirements? What are the utilization management requirements? What are the prior authorization requirements? How do we streamline those? How do we make those more consistent? And then, of course, the various types of services. As I stated in my very beginning remarks, there is no one size fits all in the Medicaid space. And so there are services that we offer that other states do not offer, and vice versa. So again, these were just some of the policy considerations that I hope will be beneficial for the commission as you all move forward in your work. And so that concludes my presentation. Chair Nagel, I will pause for any questions.
Lynette, thank you so much. I cannot think of a better teacher or subject matter expertise to help kind of all ground us in how Medicaid works today. I know that was a lot, but I think for both the commission members and even other folks that are paying attention to this work, if we're really going to get into the meat of how things work and how we can move Georgia forward, I think it's important that we all understand really the nuts and bolts of how Medicaid really pieces together to make some of this work. It gets even more complicated. And Lynette will probably call upon you again as we get into the intricacies of what it takes to even consider a waiver or a new program and how we negotiate with CMS. So thank you. Let me pause and see if there are questions from our commission members. And you can certainly reserve the right to shoot those to me or to the email address offline or follow up or think about it. But let me just pause for a moment.
Oh, Lynette, I'm sorry, this is Rusty Ross. Excellent presentation, Lynette, and it has been a while, hadn't it? One of the things I wanted to mention was, and couldn't go through this meeting without mentioning it, was the late great Judge Commissioner Clyde Reese.
Yes.
And one of the conversations we had, and we were talking about particularly how do you get people to health care? I mean, how do you get them to take better care of themselves? And Clyde and I started talking about it one day. He looked at me. I think I'm a suck. It was very simple-minded. I said, well, what if we pay them $1 if they get, some checkup or something like that? And he looked at me and said, Rusty, that's a great idea. And that was probably 20 years ago. And I think that idea has been cogitating around how can you incentivize the populace to take care of themselves in some fashion with our help. But anyway, I wanted to say that, and I appreciate your presentation. Very comprehensive. Excellent.
Thank you, Rusty.
Dr. Hyman, you've got your hand up.
Yeah, thank you. And again, I'll just echo the thanks. As someone who teaches a lot of this content, you do it better than I do, and better than most that I've seen. So thank you very much for that. Two questions. One is, and I may have gotten the numbers wrong, but I thought I saw an $18 billion number for the total costs. And then when you were breaking it down, I saw a $12 billion for Medicaid, and then in the neighborhood of a $500 million for the CHIP program. And I'm wondering what piece I'm missing? So that's question number one. And then question number two is the two 1115 waivers, the Planning for Healthy Babies and the pathways. Could you share a ballpark what the current enrollment levels are for those two programs?
Sure. So think for the first question, also have to take into account admin expenses, and which vary depending upon, is it staffing, resources, technology, systems, all of those things. And then also SHBP. So it's a combined budget for DCH as a whole.
Yeah, DCH's total budget's at 18 or 19 billion. I think Lynette's numbers later on were specific to Medicaid. And so that includes healthcare facility regulation, SHBP. Everything.
That's right. That's right.
Okay, great.
And then for enrollment for pathways, a little over 4,000 today. Of course, that number changes every day. And then I'll have to take another look and what I can do, Chair Noggle, while the next presenter starts, I'll just shoot that in the chat, what the enrollment is for Planning for Healthy Babies. That's an easy lookup. I'll put that in the chat for you.
Thanks, Lynette. Christy?
Thank you.
Hi, thank you. Again, let me echo my thanks, Lynette. It's nice to meet you. We haven't had a chance to meet before. And my questions are, I think, not really questions to be answered today, but things that I'm curious about as we continue to do our work. And I'll name three things. The first, related to Rusty, the point that you made. My question is, how easy is it to get to care if you're a person that needs care? So in what ways are we making it possible for people to take accountability and responsibility for their own health in terms of accessibility of care options for people? So that is a question on my mind that I would love to explore further with the group. The second question on my mind, and maybe you already have this, Lynette, I don't know, is any data on the 600,000 that we no longer have enrolled in Medicaid due to the unwinding? Do we know where they went? Are they enrolled in marketplace plans? Are they uninsured? So that group of people, any information we could get on where they went would be helpful. And the third thing that would be helpful, obviously with our managed care organizations, we're paying them a tremendous amount of money. So I am curious about accountability for those managed care organizations providing the full breadth and range of services that our enrolled members are supposed to be getting entitled to and deserve to have. So three areas of further consideration I have. Thanks so much.
Absolutely. Yes, and we can take those back and follow up with Chair Noggle. The one thing I do want to just address quickly is your first question, your first point about how do we get members to care? And that's an excellent question. We have telehealth, of course, and we've expanded that vastly. I think the public health emergency kind of pushed us all in that area. Non-emergency medical transportation. I don't want us to forget about that one. And then also apps. There is actually a lot of utilization of various apps, particularly for members with behavioral health type of diagnosis. So that's why I put the technology on this slide as a critical component because we think of the same thing, Ms. Davis, which is how do I get you to engage in your care? And if I know you're not going to go to a doctor's office, then maybe an app will be, the option there.
Thanks, Lynette. Any other questions for her at the moment before we move on? Won't be your only chance, and I'll follow up on a couple of those things. Thanks, Lynette.
Dr. Moore has his hand
Dr.
raised.
Moore. Okay, I'm sorry. Dr. Moore.
Sorry, I was just trying to do the math a little bit too. So what percent of the population in Georgia is covered by Medicaid?
I'll need to follow up on that. So you're asking just in terms of Georgia residency, how many of those members are actually in Medicaid? The percentage?
The number's like 2,600,000 that are.
Right. We cover 2.3 million members today. Now, what percentage of the overall population that is, I'll need to follow up on that. but our current enrollment is 2.3 million, and that's for Medicaid and CHIP.
That's probably about 23% of the population. Yeah, we're about 11 million in Georgia. Is that right?
Maybe we can follow up with that.
Okay. All right. Thank you.
Thanks, Lynette. Like I said, General John King is also joining us today. We'll turn our attention now to an update on Georgia Access and maybe ask him to talk briefly about reinsurance, which is a little bit lesser known program. It's one of my favorites. So General John King serves as the Insurance and Safety Fire Commissioner. He was appointed by Governor Kemp in 2019 and was elected in 2022. He is Georgia's first Hispanic statewide elected official. General King is a retired Major General in the U.S. Army and retired following his final assignment to NORAD and the U.S. Northern Command. He was a commander in combat theaters in Bosnia, Iraq, Afghanistan, and Africa. And prior to joining state government, he served as the chief of police for the city of Dorville. General King, you know I'm a fan and appreciate your service not only to Georgia, but to the country, and I'm honored to have worked alongside you. And thank you for being with us today. I'm going to turn it over to you.
Thank you so much, Kaylee. I really appreciate the opportunity to work with you again on this. It's such an important task. You know, I've been sitting with you all watching this presentation, and I know you're drinking water out of the fire hose, and I clearly recognize that. Our slides are not very extensive, but they're packed with a great deal of information. And so please, and I offer this to the chair and to the members of the commission, if you need us to come and give you an individual presentation or come back to the commission, if you have any specifics, we're absolutely open. We want you to be able to have complete access to how we're viewing this problem set and how we're going after it here in Georgia. Thank you so much for the opportunity to come and talk to you about this really exciting program that we have in Georgia. Can we have the next slide, please? You know, and I'm going to go through a couple of, this slide, it just kind of sets the stage for you. The Affordable Care Act established health insurance exchanges with financial assistance from the federal government, including tax credits, cost-sharing reductions to make coverage more affordable for eligible consumers. For states that did not establish their own state-based exchange, they initially had their markets deferred to the Federal Facilitated Exchange, also known as healthcare.gov. Typically, exchanges serve consumers who are 19 to 64 years of age, who are not eligible for federal programs such as Medicaid, CHIP, who do not receive employer-sponsored insurance, and are above the 100% of the federal poverty level. I'll let you all kind of absorb this slide for a second before I transition to the next. Next slide, please. Okay. Georgia Access is it's a state's new program for Georgians to shop for and enroll in healthcare insurance. Beginning November 1 of 2024, Georgia Access provide the state portal for contacts and a contact center in which will fully replace healthcare.gov for consumers who apply for healthcare coverage and financial assistance in the exchange for open enrollment 2025. So basically this coming year. In 2022, we first launched public awareness campaign for open enrollment period 2023 to drive enrollment and reach many of the uninsured. In 2023, we stood up the new Georgia Access Division and hired our executive director, who's here in the office with me to answer many of you might have any technical questions. We launched the state-based exchange on the federal platform for open enrollment period 2024. As an SBE platform this year, consumers will still enroll in coverage through the federal platform, healthcare.gov, but the Office of Commissioner of Insurance ran a statewide marketing and outreach campaign, hosted information website, ran assistant programs for over 30 communities across our great state, certified the plans sold on the federal platform, and provided a hotline to help consumers. Our Georgia Access team is completing the final readiness reviews for the Centers for Medicare and Medicaid Services, CMS, this summer. We are fully on track to transition to Georgia's market off the federal platform to the state-based this fall. Our goals are clear. Increase the number of uninsured Georgians, improve the shopping and enrollment experience for consumers, and strengthen competition, innovation, and private sector investment in the Georgia's market. And if you can go to the next slide, please. Georgia Access goals have already begun to be realized. Before Georgia's efforts started, the state had approximately 700,000 consumers on the exchange for the open enrollment for 2022 and 1.2 million uninsured. OCI, our office, launched its first statewide marketing campaign November of 2022 for open enrollment 2023 to drive enrollment and get more Georgians covered. Georgia saw 25% growth in its enrollment for open enrollment 2023 compared to the previous year. This was double the national growth of 12%. And Georgia continued its public awareness campaign for open enrollment 2024 and experienced a 48% growth in enrollment compared to the prior year. This is significant because it's greater than the national average, which is 30%. So for open enrollment 2024, 1.3 million Georgians selected health plans, the largest figure ever recorded in Georgia's market. This is nearly double what the enrollment was in 2022 before the state began its marketing and outreach efforts. So hopefully, hopefully that answers one of your questions that was earlier about where did those people went to. This is where many of them went to for coverage. Next slide, please. So Georgia Access is the first state-based exchange in the country that will also certify private sector partners to give consumers multiple options to shop for and enroll coverage. So they aren't limited by just using the government portal. Regardless of where consumers shop and enroll for Georgia Access, the service provided for consumers is free. Consumers will see the same health plans at the same prices, and consumers will be eligible for the same federal financial assistance. Consumers will be able to enroll directly with an insurance company. It will be easy and convenient option for consumers that want to stay in their same plan with the same insurance company. Consumers will also be able to enroll with web brokers. Web brokers are companies that offer similar plans, shopping, comparisons, and enrollment experience as the government portal, but with a tailored approach for specific consumer groups. For example, there are some web brokers whose business models target gig economy workers and others that target communities where Spanish is the first language. This means better and more tailored service to our residents to help them enroll for coverage. Consumers will also be able to enroll with agents in Georgia Access. We have a strong and vibrant agent network in Georgia. They're knowledgeable about the plans, and the majority of the enrollment we're seeing today happens today on Georgia Healthcare, on healthcare.gov, is the assistance of agents. Anyone who, next slide, please. Anyone who is a U.S. citizen or lawful present here in Georgia who does not receive healthcare coverage through their employer and are not eligible for another government program can enroll in Georgia Access. Consumers with household incomes above 100% of the federal poverty line, which is approximately $14,000 for an individual and $30,000 for a family of four, are also eligible for federal financial assistance to make the cost of healthcare more affordable. And consumers who make between 100% to 150% of the federal poverty line are eligible for 0% premiums when selecting a silver plan on Georgia Access. Over 834,000 Georgians between this income bracket today are buying on the exchange are eligible for 0 premium health plan. Consumers below 100% on the federal poverty level are not eligible for federal financial assistance on Georgia Access, but will be referred back to Medicaid. These consumers are eligible to receive coverage through Pathways, Medicaid, Peach Care for kids. And consumers above 400% of the federal poverty line, which is approximately $58,000 for an individual, are typically not eligible for federal assistance, but can still enroll in coverage in Georgia Access. We have worked really hard between us and DCH to make sure that we capture those folks that are coming off, the Medicaid rolls, that we are there standing and ready to provide them options. And I think that's one of the big highlights that we've been able to learn this year. Can we get the next slide, please? Consumer subsidies. The federal government pays 100% of the financial assistance for eligible consumers who enroll on Georgia Access. There are two types of financial assistance: federal premium tax credits through the IRS, which are paid up front from the federal government to insurance companies to lower consumers' monthly premiums, and the cost-sharing reductions, which lower consumers' total out-of-pocket costs for receiving health care. The Georgia Access implementation, the General Assembly has allocated funds for our agency to implement the Georgia Access. But in the future, the ongoing operations, Georgia Access charges 2.5% user fee to insurance companies selling plans on Georgia Access. This is the same as the mechanism that the federal government uses to fund healthcare.gov. A user fee is a percentage of that premium. And the user fee has remained the same for Georgia insurance companies from 2023 through 2025. But the funding goes to the state under Georgia Access rather than funding the federal government. And so those funds that are generated through the running of this program get invested into the, as Kaylee mentioned, the high risk pool, which is the reinsurance program, is to help stabilize that. And that's really what's driven a lot of the companies to go and compete in counties across the state. That when we first came into office, we realized that we had a crisis where we had counties that only had one provider, competing for business. Next slide, please. Historically, Georgia's marketplace has been plagued by limited coverage options, lack of access in rural and underserved communities, and high premiums. At the same time, the state had one of the highest uninsured rates in the country. Between 2016 and 2019, total enrollment in the federal exchange in Georgia declined by 22%, with over 129,000 consumers leaving the market. At the same time, the state had more than 1.3 million uninsured Georgians, which many of them were eligible for federal tax credits and cost-sharing reductions to limit their out-of-pocket spend. To address the challenges in the market, the Georgia General Assembly passed Georgia governor signed the Patients First Act on March 27, 2019, granting authority to pursue innovative strategies under the ACA Section 1332 waiver for providing Georgians with access to high-quality, comprehensive, and affordable healthcare insurance coverage. The state took part in this approach to address these challenges. The first was to implement a reinsurance program to lower premiums and attract more carriers to the market. The second was to transition off the federal exchange to bring oversight of Georgia's market back to the state and increase enrollment. After the federal government suspended Georgia Access under the 1332 waiver, the General Assembly passed the last spring to pivot and implement Georgia Access as a state-based exchange. And with that, I will pause and open it up for any questions. I have Cheryl here, who's the program director, for any of the technical questions. But I hope this provides some kind of an overview. And I know you've been absorbing so much information in just the last couple of hours. So please know that we're available for any additional follow-on presentations or any particular questions you may have as you go through this next 2 years. With that, I'll pause.
Thank you, General King. This is a fantastic set of 8 slides packed with information. I think it's really important that as a commission and those watching really understand what this program is and how it works together. I've often said, and explained to folks that Medicaid is really like the safety net program for folks that have no other options. And I think for many of us, I think some of us would agree, or at least from my opinion, coverage is good for individuals, really regardless of where it comes from. And there are a lot of folks taking advantage of this program. And I think, General King, you just highlighted some numbers, I think, that were even new to me. I'm sure we'll come back to you with some more information. But let me just pause and see if there are other members of the commission that have questions or thoughts on this.
Kaylee, let me just add is that we are marketing this program by going to local communities across the state and having a micro message that's appropriate for that community. And so, because we understand the Georgia market probably better than it's not a poke at the federal government, but we just understand Georgia a little bit better. And so we're going to, for example, the high school football game in Lowndes County against Valdosta. We're going there and we're setting up our bus and information booth with trained folks that can talk to folks about. When we go to Gainesville, we have people that can speak Spanish, because we know that in Dalton, those populations, need to have somebody that can speak language and understand culture. And I think that's one of our biggest keys to success. On top of that, we've had the carriers stay in the market and compete for this business, because they see that this is obviously a very innovative and potentially a way that the future of the healthcare is going to be, provided to Georgia residents.
Thanks, John King. Questions from the commission? Christy.
Yeah, thanks again, Kaylee, and nice to meet you, General King. We haven't had a chance to meet before. One of the things I am curious about, and again, perhaps not for today, but for later, is the consumer experience in these plans. So you talked a little bit about enrollment experience, which is great, but thinking about when somebody enrolled in, particularly our moderate income Georgians are actually trying to access care through the plans. If we're doing anything to just understand their experience again with getting to care, and the quality of their perception of the quality of care they're receiving using their plan would be tremendously helpful. But again, thanks for the presentation, really helpful and really great to meet you.
I will tell you, thank you so much, Christy. This is a great question, by the way. I would tell you, I have Cheryl here that can add some, but we are not relying on one method of engaging and getting people interested in, and we're really getting people to understand what are they buying when they buy healthcare coverage. And so that's been we spend a lot of time on the education piece. And then we now, because we are the insurance commission, we hold the licenses for these companies. We also hold the companies accountable when they fail to meet those goals. And so unlike the federal government, we actually have the tools to correct behavior. So our antennas and our engagement is really tracking that experience. And if a company falls short, we're going to hold them accountable and get them a corrective action plan. So that's what makes it different because we have the full authorities versus the federal government that has some lesser authorities than we do.
Thanks, Commissioner King. And I'll just add to that. This is Cheryl Gardner. The other thing I'll add to that is no one cares more about the consumer experience than Commissioner King. And so one of the things he did this year, and we were really happy to be able to accommodate this, was he commissioned a statewide survey. We surveyed over 10,000 households in the state, representing 30,000 Georgians, about some of their preferences, what they would like to see in terms of the consumer experience. We followed that up with, and we're still in the process of this now, holding 31 focus groups around the state to get a little more in-depth on that. So we feel like we have a good finger on the pulse of what consumers would like to see. Commissioner King was exactly right too, that our intent all along has been to meet Georgians where they are. If they want to enroll through their insurance company, we're going to let them do that. If they want to enroll through their agent or broker, we're going to let them do that. If they want to enroll through the state portal, fine by us. We actually don't have any preference for where people get covered. We just want them to get covered. One of the great things about Georgia Access too is that we are using the enhanced direct enrollment, the web brokers that he mentioned. We don't know exactly why, but people tend to prefer these. So this is something that healthcare.gov started doing back in 2019. Instead of saying everybody has to come through the front door of healthcare.gov, the federal government started letting them go through several different resources. And we'll be the first state-based exchange to allow that very same thing. And as we have interviewed people and brought them into focus groups, some of the feedback that we've gotten was, hey, we like this one particular web broker because they really gear everything towards Spanish-speaking population. We like this other web broker because they gear their enrollment experience to the gig workers. And so we think that there are a lot of people out there to help meet those needs. And for those people who don't necessarily have a preference of an agent or a web broker, then they can go, if they just want to stay with their plan, if they like their plan and they really genuinely do want to keep that plan, they can go through their plan or then come through us. We don't have any preference as long as they get covered.
Thanks, Cheryl. Dr. Hyman, I see your hand. I want to share one data point that Lynette dropped into a chat that just to make sure that you can all see it to answer a question. There were 366,000 members who were on Medicaid in March of 2023, who between March of 23 and March of 24 subsequently enrolled in private marketplace plans. So I think that's speaking to that group that had Medicaid, that have transitioned or through redeterminations chosen now a private marketplace plan, potentially with federal subsidy. So that's a great data point, Lynette. And she sent a source file for that data as well that I'll be sure to share. Dr. Hyman, you had a comment or a question.
Yeah, I was just hoping to contextualize some of the data that was shared. And Commissioner King, I'm not sure whether you prefer commissioner or general commissioner. You have
John will work just fine, doctor.
Okay. Well, then please skip the doctor and go straight to Harry. I appreciate that. So just looking at the slide that's in front of us of 2019, I know starting in 2020 with change in administrations at the federal level, there were changes made in the level of federal premium support in terms of tax credits. So I just want to get a sense if we can understand the impact of that, and then the restoration of funding for navigators to help make people aware. So that's kind of one question. And then the 1.3 million uninsured in 2019. I'm wondering how that compares with the number now in 2024, kind of after the unwinding after the public health emergency, because I think the number's gotten close to that. I'm just curious whether you're aware of what our or your support staff is, what our current number of uninsured people is in our state.
I'm making notes on potentially a subsequent presentation for the group, Dr. Hyman, where we can kind of look at Georgia holistically of all the buckets of the population. John, Commissioner King, you can chime in now, but I'm certainly envisioning perhaps a next presentation for this group that looks at everything holistically.
I would like that opportunity, Kaylee, and the rest of you, the commission, because we are doing the survey. We already did the first part of the survey, but then we're going to follow it up with some town halls. And I think that'll be useful for this commission to get that feedback. But the numbers are tremendous in the initial look. But obviously, we need to have a complete look across the state, and I think it'd be something that could be of value to Madam Chair and the rest of the committee as we go around Georgia, get the feedback, and then be able to apply those numbers and then balance it out with our partners at DCH as well.
Thank you.
Del Vecchio.
Yeah, probably more a series of comments than a question, but I definitely want to echo my thanks to both presenters. Well, I'm going to say John because you said it, although I got to say that feels really...
You're a Grady baby. Definitely you can call me John.
Right on. I appreciate that. But wow, quite impressive. But to both of you, this has been a really rich primer and background. I know all of us are going to have to digest it more. You made a comment, John, that I think reflected and echoed a sentiment that Kaylee made too in her opening remarks about us really having contextual awareness for the different options that exist in terms of what's happened here and then across the country, but really having a Georgia-centric sort of focus. You talked about kind of how your efforts have really been leveraging the fact that you and your team really know the state. And I think as we dig into some of the additional data that looks at what our current state is across the state, some of my colleagues referenced in their remarks where we're coming from and what our lived experience has been. And I think we know that this is a very diverse state, right? So what happens in our metro areas is different in our rural areas, as we talked about in terms of different sort of subsets of population, people who are in gig economies and other sorts of endeavors and others have a different, unique set of ways in which what they're challenged with and experiencing, but then ways in which we can both support them and encourage them to take control of their health. So I think as we look forward to getting deeper dives and subsequent discussions, our best ability to have that level of not sort of granularity, but depth of understanding in which to inform some of the recommendations that we might make would be incredibly helpful. And I just appreciate everything you guys are offering.
Rusty?
Yeah, I'm sorry, I had to unmute myself. My question has to do with the payor side, the insurance company side, and I just need to have some you think they handle. I mean, is this an individual by individual policy determination that they make? There any sort of dynamics that would go into select or into determining premiums, that sort of thing, and the baseline of services that they have to provide for that participation. I just be interested if there's a source that we can go to and look at those questions and hopefully answers.
Yeah, I think there probably is. And Commissioner King, if okay, I might call on Cheryl offline to maybe help me gather up some sources. There are some federal standards related to what qualifies as a basic healthcare plan that's offered through the exchanges in terms of what has to be covered. Same with what has to be covered on a Medicaid by CMOs. And so we can get you some of that information and see if we can get some of those questions for you.
Madam Chair, is all the plans offered have to meet the federal guidelines, so they can't be less, but all the companies are allowed to go and market additional. They have to meet some basic criteria, the same as the federal criteria is, but then they have to offer if they want to, they can offer additional enhancements to that basic coverage. And that's what the targeting for the gig economy, the Latino market, folks in ag, folks across Georgia. That's where those companies are really excited about competing in that space. And so that's what makes it a real viable marketplace of competing for market share and for opportunities to cover. Ultimately, I came to this focus because I was an Atlanta police officer working the streets of Atlanta, and I know what happens when people don't have coverage. They go to emergency rooms to get medical treatment, which is the most expensive, most inefficient way of getting healthcare. And so I knew that Georgia, we could do better. And that's really what's driving me and my team to make sure that we have options for those and help them make the best choice for them in the individual market.
Thanks, General. Pam.
Thank you. So I don't want to get ahead, Chair Noggle, but just thinking about future state and kind of a lot of information to digest, and certainly a significant charge within the commission's work itself. I'm sure you've been thinking through what sort of information we do need to put in front of the commission and begin to think about and peel back. And so when I think about the charge before us, certainly going back to that claims data, looking at and what can we have access to or have put in front of us relative to this specific population that we're concentrating this work around, low income, uninsured, that could certainly help to focus efforts and conversation if we were looking at high impact. So what does the claims data tell us in terms of what's occurring with this universe that we're focused around, and then how can that possibly focus some conversations going forward? So just a comment for future state.
That's a great suggestion. Thank you. Lisa?
Thank you. I agree with the sentiments earlier, and thank you for presentation. Overload of information, and my brain is certainly on fire in a good way for sure. And one of the questions I have, and certainly doesn't need to be answered today, maybe for a future presentation, what would be interesting for me, just when we put on our data hat, is what have we done on the state level for forecasting, predictive modeling. I mean, certainly we're going to have this going for about 2 years. So what I would be interested, it's great to see what our current state looks like, but certainly what do you project and what do you forecast and what does your predictive modeling data look like for 2026, 2027, future years to come? And how does that compare with access and certainly compare with what the poverty lines are going to look like in the state of Georgia, so that we're certainly building something for the future, not just for our current state.
Great point.
Madam Chair, I could probably give you a little bit of preview. That is one of the things that we really focus. And unfortunately, the federal government, they have to deal with the whole nation. And so we're going down to zip code level to really understand how the market, how dynamic the market is. And so, because we want to be able to provide that analysis to where would we shift resources. And the beauty of Georgia Access is they'll be able to be tailored based on the changes across our state, across our economy. And with all these new, opportunities for employment, we know that this is a very dynamic environment. And so we're ready really to study. And that's what the purpose of the survey is, to get a baseline of where we at and then adjust it as we go in future years.
Thanks, General King. Thank you both, General King, and to Lynette Rhodes for both your presentations and your work. I know that your jobs every day are not easy ones, and we certainly appreciate you. I've made a few notes, and we'll probably follow up with both of you on potential ways that we can engage you in this work as we go forward. We are about out of time. I've got a couple other things I want to cover, but I've taken some notes today, and so just want to share this quick thought with y'all. I've heard potential opportunities for us to look at quality of our managed care organizations, the quality of private plans on the exchanges, Medicaid member accountability, insurer plan accountability, population modeling, predictive analytics, claims analysis. And so I have been known to say, as many folks do, like, we've got to be careful and recognize we can't boil the ocean, and we're going to go back to, we've got to get to something meaningful, hopefully by December the 1st. And so I'll take some of this and we'll have to narrow down where we're going to spend our time and really think through what our goals are and where I can move us towards to getting to something put out in December. We have 2 years to get through some of this. And so it's just kind of a staging and a timing of how we want to approach some conversations. So I may follow up with a couple of you, but just keep that in mind. We'll have to be a little intentional about how and when we look at things, and also some external factors that may influence some of those conversations that we have now versus later. As I chart and think about that path going forward and some of those topics, I would like your input, commission members, on our meeting cadence and our format. I've talked to each of you a little bit about that, but I've really kind of proposed, I'm thinking about every 4 to 6 weeks, mostly via Zoom with maybe a once a quarter in-person meeting, but I'm flexible and open, and I really do want to hear your thoughts on both the cadence and the format. And if folks are willing to travel, I know we have commission members in Macon and Savannah and kind of up closer to Metro. And so would ask that each of you use the email address for the commission that will get to both Sean and I, and hopefully by Monday or Tuesday of next week, really let us know your preference. Or if you're just flexible and don't have one, would like to hear from you either way. Likewise, from time to time, we may find it valuable to invite other external parties to share some testimony with us. And I want to take your suggestions on that when appropriate as well. But I really want to encourage us to focus our time and testimony on those individuals and organizations that have subject matter expertise and can contribute to advancing our work towards a meaningful report of policy options. So we'll be a little bit thoughtful on who we invite and how we kind of curate those conversations. I know this was a lot today, a little bit of how the sausage is made, but I think it was an important first conversation for us to all get through together as we kind of ground ourselves. So again, thank you. I'm going to get you out of here on time at 4 o'clock. All of the presentations and these materials will be posted on the website. So look for those. If not already up, will be up shortly. Feel free to reach out with questions afterwards, and I will certainly, I or Sean or Kai will be in touch with next meeting dates. And we may try to do a block of dates, go ahead and set the next couple of months or set next couple of meetings all at once so we can all plan our calendars accordingly. But thank you so much, and we'll be in touch. Appreciate you and your time and attention today.
Thanks, everyone.
All right.
Thank you. Thanks, Sean.
Thank you.